My name is Sabwe Tshibanda. I'm a medical doctor. I'm from DRC, Congo, but living in Botswana. So I'll be taking you through a research proposal for prevention of mother-to-child transmission of HIV in Botswana. So, as you know, a human deficiency virus is a form of the retrovirus, and the retrovirus is a type of RNA virus that attacks the DNA, treating it as an intermediary for its replications. The process is always referred to as a retro. When one contracts on HIV without treatment, it will develop into AIDS. And as you know, the virus load rapidly develops itself in the DNA during the first 1 to 12 weeks on obtaining the virus. Afterward, they undergo a latency period of 6 to 10 years. This viral load will then arise during the stage of that a person is said to have AIDS. Botswana is one of the countries in the sub-Saharan Africa, is rated as the third with the most prevalence in HIV infection. The state has made the adequate effort to try and reduce HIV infection rates. In this paper, we will review an overview of the PMTCT of the current state of HIV in Botswana. Also, it will highlight some reasons to why there's a high percentage of MTCTC in the country. This paper also gives away to integrating faith-based strategies in the administration of the PMTCT and option B+ strategy in the fight against HIV. Talking about the prevalence, according to the report by World Health Organization on statistics concerning regional HIV among women, it was evident that sub-Saharan women constitute 60% of all women across the world that are living with HIV. And especially in Botswana, it is noted that the prevalence rate has reduced since the year 2003 due to a different program that was put in place by the government and other institutions. Furthermore, other reports suggest that the national prevalence of HIV infection through MTCT is the most common means of HIV transmission in the countries such as Tanzania, Nigeria, and Ghana. Botswana has recently been affected by the new strategy put in place to eradicate this epidemic nature of HIV/AIDS. What are the efforts done by the government to fight HIV? So in the year 1999, the government of Botswana introduced the initiative to prevent the spread of HIV known as the Prevention of Mother-to-Child Transmission, PMTCT. Later on, Gates Foundation, in collaboration with Harvard, AIDS, Shem, and other pharmaceuticals firms, such as Merck kicked off a treatment program in August 2010. In this program, the use of antiretroviral drugs was administered to those with the late stage phase of the disease. Furthermore, the government launched the first ever national strategy plan to fight HIV/AIDS epidemic in 2004 through conducting routine checking for each citizen. In the year of 2011, the Ministry of Education, in collaboration with the Stanford University launched a teach-aid software that was designed to educate locals on the significant steps to undertake to minimize HIV infection. As seen above, these are the efforts that the country has actively taken to fight off HIV infection. Additionally, the collaboration of PMTCT and the Option B strategies has yielded a commendable outcome regarding the prevalence rates of HIV in the country. Literature review. First, with other African countries have implemented the uptake of PMTCT service, it is evident that the program has significantly impact on reducing the epidemic nature of HIV. According to a cohort study in Tanzania, it was noted that the implementation of the PMTCT service in collaboration with the Option B+ have shown a greater improvement in the initiating mothers and children who are HIV positive to follow up the antiretroviral treatment fully, even though the women within Tanzania have low income level. Additionally, in the study conducted in Nigeria, it was found that some social cultural factors influence the implementation of PMTCT, such as employment level, as well as the role of culture in the implementation of PMTCT program. Another study in Ghana suggests that the knowledge level of HIV positive women on heart therapy and PMTCT primarily affected the adherence heart antiretroviral treatment. In Botswana, the PMTCT was collaborate with the use of the Option B on and accounted to reduce the epidemic level of HIV. The current situation in Botswana indicated that a child's survival depends on the maternal health. Therefore, the condition of the mother will affect the survival of the infant. Maternal health conditions have a relationship in the transmission of HIV from the mother to the infant because of the greater virulence of infecting strain. Additionally, poor transfer of passive immunity through breastfeeding has increased the maternal infant burden of HIV. There are different factors that have impacted the implementation Option B+ and the PMTCT programs. As a study by Ndumbuka, Marshall and others suggests that HIV infection women in Botswana need to be more knowledgeable and informed about infant breastfeeding attitude and practice so that children can be protected from MPCT. Socio-economic factors as primarily affected by these two projects in the country. Researchers have suggested that the PMTCT program in collaboration with the Option B+ have created more positive outcomes in the fight against the HIV epidemic in Botswana since time immemorial. Evidently, the best uptake for PMTCT rose from 49% in 2002 to 98% in 2014. The program uptake increased from 27% in 2002 to 95% in December 2014, as well as an integration of PMTCT into SRH service and introduction of counselors to the program to help subjects understand the importance of such a program. Option B, or the lifelong heart, refers to as the use of drugs therapy for the prevention of mother-to-child transmission in all HIV positive pregnant and breastfeeding women, despite the consequences of CD4 decrease in cell count for the rest of their life. Research suggests that using antiretroviral treatment has been more effective in reducing transmission rates and its cost efficient. Nature puts it as a simple program to implement within the country. Use of option B has also met some challenges in Botswana because of the presence of a weak community-based therapy support, a reluctance of female to start hard, infant feeding issues, shortage of human capacity, and so on. Option B has impacted positively in the other countries such as Malawi, in that it has reduced HIV transmission through the country. Recommendations in merging the two programs, the implementers such as government and other involved agencies are faced with the same difficulties as they have to consider many factors such as the social structure, cultural structure, and economic factors. Further, most of the researchers have not evaluated the impact of faith on these two programs. If given an opportunity, my research will majorly focus on how faith-based beliefs affect the implementation of option B and the PMTC program. Furthermore, a focus on educating the public through translators and faith leaders is a key factor in boosting the outcome of the two programs and overcome barriers to full implementation such as political tide and male involvement and participation. Conclusion: Botswana was once rated as the third country with the highest HIV prevalence rate around the world. But the government has been able to fight off the prevalence rate to minimal figures through the implementation of the PMTCT combined with the use of option B. The program can be said to be successful, although the Vision 2016 has not yet been achieved. As the concerned parts strive to implement the program, challenges are present, either socio-cultural or economic. In future, research must be undertaken to weigh out the influence of faith-based belief on prevention of HIV in the country. Thank you very much.